Welcome back, everyone, to Part B of Chapter 11. The primary focus of this lecture will be the NSAIDs, the non-steroidal anti-inflammatory drugs, with some discussion about some neuropathic pain and some other types of issues at the end of the chapter. There's a little bit more about some cancer-related pain and so forth at the end. But mostly it's about anti-inflammatory NSAIDs. Moving on from opioids now, we're going to talk about the non-steroidal anti-inflammatory drugs, the NSAIDs, sometimes called COXIBs. These are cyclooxygenase inhibitors. These are a little bit more specific. Non-specific NSAIDs include ibuprofen, naproxen, sodium. These are very, very, very common. And so let's talk about their analgesic effects and how we incorporate. This is a really nice figure encapsulating the biology of cyclooxygenase. Whether it is cyclooxygenase 1, which we call constitutive COX, or cyclooxygenase 2, which is induced by inflammation, both convert arachidonic acid to a compound known as a prostaglandin. And so COX-2 is more important in the anti-inflammatory, analgesic side of the equation. COX-1 is found in other tissues and may be involved in other activities within the body, including the adherence of platelets and other GI tract sort of things. And so a lot of work is being done in order to be more specific to cyclooxygenase 2 with COXIBs. Non-specific NSAIDs will block both, and there may be side effects associated with that blockage. Yet another really great figure showing these major NSAIDs, aspirin, acetaminophen, and then ibuprofen, that show the basic responses regarding analgesia and inflammation. And what we see is that aspirin, while maybe not as potent as, say, something like ibuprofen, does reduce inflammation, does reduce itching, so it may have some things that are affecting the histamine side of the equation. Acetaminophen is maybe a little more potent than aspirin and can reduce fever, but it doesn't really do a whole lot for itching and inflammation. Whereas ibuprofen is a really great anti-inflammatory that has a higher ability to induce analgesia. And so aspirin's been around for a long, long time, well over 100 years now. Not around as long as heroin or some other things, but it's been around a while. It's had long-standing analgesic known to have analgesic activity by being an inhibitor of both cyclooxygenase 1 and cyclooxygenase 2. It's also involved in the synthesis of thromboxanes through an enzyme called lipoxygenases that I mentioned in a previous online lecture. And so it can be used in a number of fashions, not only for analgesia, but at low dose can inhibit platelet aggregation and risk of clotting and thrombosis and embolism. The low dose side of it has become more controversial as of late. There have been some conflicting studies, but I would guess at this point, low dose is still something that people will be recommended to take if they have had, particularly if they've had issues with potential for myocardial infarction. There are side effects to aspirin, given that it's a non-specific cyclooxygenase inhibitor, but also probably inhibits other enzymes like lipoxygenases. The number one concern, the most significant concern, it's not the number one most common, would be anaphylaxis. If someone is allergic to aspirin, that can become very, very serious very, very quick. And so the standard, anaphylactic responses are detailed here. Fast heartbeat, difficulty breathing, swelling, and so forth. Another potentially very dangerous side effect of aspirin, and why we don't see a whole lot of aspirin being given to kids anymore, is the risk of Reye's syndrome, which leads to ototoxicity. It's a rare but significant response to aspirin. And again, that's one of the reasons why we don't see pediatric patients being prescribed aspirin as much as they used to be. And then lastly, and this is the most common, is that particularly if you're on chronic aspirin, it can irritate the lining of the stomach. And so you can get nausea. It's a mild acid, so there may be some other things here in progressing severity. If it's affecting the colon, you might see bright red blood. If it's blacker or more tarry, that means that it's probably more upstream in the stomach or in the upper small intestine because the blood's being digested. And so what you're seeing is digested blood versus undigested blood. When it comes to aspirin overdose, there are quite a variety of effects that can be occurring, and it may be a situation of variability when it comes to aspirin overdose. On one hand, aspirin is inhibiting the cyclooxygenase enzymes, which are lipid metabolizers. More aspirin may be covering more lipid metabolism, which can lead to acidosis. On the other hand, there are patients who are sensitive to aspirin in that it will stimulate hyperventilation and lead to respiratory alkalosis. And so it gets really, really complicated really, really quick. Electrolyte loss is a big issue too. You can get dehydration and ion depletion due to aspirin overdose. And so a lot of the time what they're going to try to do is watch the blood pH, try to manage fluids and electrolytes in order to mitigate the symptoms of aspirin overdose. And so more patients than not will actually experience acidosis due to aspirin overdose. And so what's going on is here is aspirin right here. Here's this proton. It'll donate a proton to the blood pH, and then that will drive creation of carbonic acid and then CO2. And now maybe this is also the reason why it triggers hyperventilation, but it seems to be excessive hyperventilation. So we might see acidosis that then, because of hyperventilation, turns into alkalosis. But most patients who are elevated in aspirin are going to be acidotic. Kidney function, what we might be inhibiting renal function, which leads to dehydration, loss of ion. Above and beyond aspirin, we have lots and lots of other drugs that are much more, to varying degrees, specific for cyclooxygenase 2. And these are all very, very, very common. Many are over the counter. Some are prescribed for various reasons. Strength is among them, or if they're combined with an opioid or something. And again, what we're trying to do is get after this side of the equation. Things over on this side include, protective mechanisms that protect gastric mucosa. And so that's part of why aspirin may be damaging the gastric mucosa, is due to the fact that it's inhibiting cyclooxygenase 1 as well as 2. Spermatogenesis is actually modulated by cyclooxygenase 1. So there are a number of functions out there that depend on it. So again, lipid metabolism. On the other hand, this is the one we get at, so we go after cyclooxygenase. We found out, unfortunately, though, that COX-2 inhibitors may potentially increase untoward heart disease events. And what we think going on is that that in the cardiac tissue, you need to have a ratio, kind of like LDL to HDL, only it's thromboxane and prostacyclin. And what we think going on is that because we're knocking down the prostacyclin, we're not knocking down the thromboxane, that it may be leading to increased cardiovascular events. And drugs have been withdrawn from the market for that reason. Another major consideration involving the use of NSAIDs and COX-2 inhibitors in particular is that we regulate glomerular filtration rate using the cyclooxygenase enzyme right here in this spot. This area is known as the macula densa. It can sense flow. So if we have a high filtration rate, what will happen is flow and osmolarity will decrease. The filtrate will be more dilute, and flow will increase. Because there are so many transporters down in here, if you have higher flow, you'll saturate those transporters quickly, and so much material will get past them before they can take it up. And so you'll see decreased osmolarity and increased flow. And that in turn will cause vasoconstriction in this afferent arteriole, maybe a little bit of vasodilation over here. In any case, it will lower pressure in the glomerulus, leading to less flow. And that's controlled by prostaglandins, which including some by by COX-2. COX-1 is also here, but COX-2 as well. Excessive excessive administration or chronic administration of cyclooxygenase inhibitors will cause a clamping effect on that afferent arteriole, which leads to reduced glomerular filtration rate, and now they're retaining fluid that they shouldn't be. They might have edema, they'll stop urinating, and it can lead to very, very serious nephrotoxicity. A very highly used drug that has a relatively good profile in terms of benefit to side effect is acetaminophen, also known as paracetamol if you're in the UK or in any of the current or former British territories. Not quite as potent as aspirin or ibuprofen or naproxen, but it doesn't have the side effect profile like, for instance, kidney damage or liver damage like you could have, or GI upset that you have with aspirin. What's really wild about acetaminophen is that its mechanism is just all over the place, and that may be the interesting part of it, is that it may be it's inhibiting COX enzymes, but it may be also interacting with several other described neurotransmitter pathways involved in nociception. This is a nice cheat sheet. Really good because, again, one NSAID doesn't really do the job as well as another for different types of situations. And so this cheat sheet, I would recommend you have one of these around so that you can sort of identify what the major risks and benefits and limitations are. For instance, acetaminophen is no good for inflammation. So if you injure yourself, it's not going to dial down that inflammation. But ibuprofen works really well. Naproxen will work really well. And the difference between ibuprofen and naproxen is time of onset. So you can look at this and weigh out your criteria. It's a really good little cheat sheet for you. To begin wrapping up the NSAIDs, among the most common side effects you see again are gastrointestinal. With in some cases, depending on how much they're using it, you might see renal issues. Again, the renal toxicity is a major issue, especially in with chronic high dose use. And that's really what this is about, is that if you see patients using these things, especially if they've been using for a long time, how many are they taking, what agent are they taking, how much, and how often. Patient use is the most common source of side effects when it comes to these drugs. Our final section for this lecture gets after a real bugaboo when it comes to pain, and that is neuropathic pain. And neuropathic pain is pain that seems to originate within the neurons themselves. So it can be because of viral infections or nerve injury, compression, can be exposure, and neuropathic pain may be induced by for instance, dependency on opioids or alcoholism, that sort of thing, withdrawal, if you will. Certainly you can get phantom pain that is neuropathic because there is no arm or finger, that sort of thing, to be injured. It's gone. Other disturbances, cancer-related, nutritional, and so forth, can all contribute to it. But it's very, very difficult to treat. It can be a real tough nut to crack. Certainly, opioids will play a role, but again, with the administrative burdens, that can be difficult. So what's the difference between nociceptive pain versus neuropathic pain? Is that nociceptive is a direct response to tissue damage or potentially injuring stimuli. Neuropathic pain may be injury, but a lot of times it's not injury at all. So it's no longer protective in the way that it's trying to alter behavior like nociceptive pain is. And then you can get this mixed type where you might have nociceptive pain that with healing that is not entirely back to the original architecture of the tissue may induce aspects of neuropathic pain in that healing process as secondary. What I really also like about this chart is that it shows you how different types of pain may be more nociceptive versus leading to mixed type. Like arthritis is nociceptive and then may induce neuropathic pain and so forth. So I really like this figure from how it sort of tries to relate nociceptive versus mixed type versus neuropathic. Symptoms, again, it's not a highly localized pain. It's a more of a regional feeling of pain that involve pins and needles or burning, shooting, irradiating pain, if you will, or maybe you also have loss of tactile sensation coupled with pain, so forth. An interesting form of what might be neurogenic pain was known as reflex sympathetic dystrophy. And what it is it's a disorder that causes longer lasting pain. It's usually in a distal appendage like an arm or a leg. And what it does is it shows up after injury or stroke or even sometimes in heart attacks. It's kind of wild. The thing about it is that the pain is often worse than the original injury, and the causes are not entirely known. It used to be called, like I said, reflex sympathetic dystrophy syndrome. It's more often referred to as complex regional pain syndrome. But it doesn't have the regular characteristics. What we think is going on is that the injury or the inflammation activates the sympathetic nervous system, and what happens is that you may cause them to initially to contract. So like your sympathetic response in the hand causes the blood vessels to contract, and then there's this rebound. So initially they contract, and later they rebound open and leads to this edema response with lots and lots of pain and swelling. So it's this rebound or reflex sympathetic dystrophy. So initially you'd have vasoconstriction, and then secondarily you get this wild vasodilation coupled with pain. Unfortunately for us, we will see neuropathic pain in the clinic. It is a very, very common thing. 50% of all pain clinic visits, up to anyway, are neuropathic. It's difficult to assess. People don't fully understand it and may lead to presumptions of the patient. They think that maybe, somebody's a snowflake or something. There is a lot of variability in response to treatment. This is part of the inroad that marijuana and the cannabis camp is using, is that there are people who do respond to cannabis or the THC therapies that maybe other patients don't. But that's certainly a very large area for why the legalization effort is going on. Like I said, patients are often not believed. They just think it's a weakness of their character. It is complex because it could be caused by any number of possible etiologies. Lastly, let's talk about cancer pain. When you have metastatic pain, uh, uh, what's going on is that the cells are invading the tissues, and usually by the time this pain ensues, that the patients know that they are probably terminal. And so there is physical pain, but there's also a very large emotional and spiritual pain to this as well. So cancer pain is complex and it is severe. Where we see the most severe is in the bone. Certainly other ones are nearly as severe. Again, oral is probably in the bone as well, but you can see that different types of pain due to different types of cancer, if you will. One of the major therapeutic issues with cancer pain is that it is persistent, it is chronic, it can be relatively severe, and it flares. So in cancer patients, there's this term known as breakthrough pain. It refers to this sort of transitory flare of pain, even though the pain is, we're attempting to manage the pain with drugs, including opioids. We don't really know what's going on. It's probably due to, I'm going to guess, it's probably due to release of cytokines that are then triggering some of these things, but it still hasn't been fully understood. And so breakthrough pain is a real nasty issue when it comes to, it's particularly bone metastasis. As I mentioned previously, cannabinoids are making some inroads, particularly in patients who are terminal. Some early studies, with a relatively small population who are non-responsive to opioids and so forth. They did see a statistically significant effect. 43% of the patients showed some improvement in their pain when administered cannabidiol or THC. So it's promising. It's promising. There's no doubt about it. There will be a role for cannabinoids, um, but according to some of the clinicians that I'm familiar with, that they do see rebound pain. They're starting to see a sort of pain hypersensitivity, not unlike opioids. Now that we're seeing many, many, many more patients going to cannabidiol and THC to manage pain. That's one of the things that's ongoing, is that we're seeing some pain hypersensitivity. And so that wraps up this chapter or these two chapters, I should say. Again, follow along with what we've gone with the PowerPoints. Make sure you do use the reading alongside it. Don't be afraid to dig a little deeper with the reading. Make sure that you have the basics down good so that you don't have to work too hard in being, part of learning about pharmacology. I haven't maybe articulated this as well as I could, because there are so many agents and potentials for side effects. What you want to do is have those ADR possibility, that awareness, and again, repeated exposure. It's one of the reasons why I've kept the exams open notes, sometimes open book, not to make the course easier, but to incentivize you to get more repetitions with this material, because the more you use it, the more useful it becomes. So thanks for your time, and I'll hopefully see you soon. Take care.